Thank you all for joining us today. Welcome. Welcome to our program on the status and future outlook of Health Information Exchange. This is Kate Berry, CEO of National eHealth Collaborative. And we've got a really, I think, a great program today, and we're just delighted that you've all joined us. We have really two major pieces to the agenda. We're going to have a discussion of a couple of HIE leaders talking about two different examples of what's happening out in the marketplace. So we're excited about that. And then the second main portion of our agenda today will be to share some updates from the NeHC HIE Learning Network workgroup. So we'll have some reports from the chairs, the volunteer chairs of those work groups. Just to put a little bit of this in context as we get started, and you can go to the next slide, Ernest, please. So we launched this HIE Learning Network after we released this Health Information Exchange roadmap paper early in the spring, and we had many stakeholders who participated in developing and providing input into this paper, and then we launched this HIE Learning Network, which is really focused on providing a collaborative forum to tackle issues and to share lessons learned and best practices to try to accelerate progress toward widespread, sustainable health information exchange that will indeed improve health and health care. So we're really pleased. We've had such a tremendous level of participation in the Learning Network. So we think it's focused on the right things. We have found that we're trying to address a really important area of need. So, and working with the participating stakeholders, we actually prioritized among a very long list of potential issues to work on together. Our participating stakeholders prioritized the top 4 issues to tackle, and so that's what the work groups are focused on. When we'll get to those updates very shortly. But I do want to get to our HIE leaders, and we have Hunt Blair from Vermont, who's going to lead us off, and we also have Doug Dietzman from Michigan Health Connect. So we've got their pictures for you, so you can, if you don't know Hunt and Doug, you can see them on your screen. And I also want to make sure that we try to make this program as interactive as possible. So for those of you who haven't already participated on our many webinars, please type in your questions or your comments in the Q&A function at the bottom right-hand side of your screen, and we will do our very best to get those comments and questions in. So after Hunt and Doug chat for a few minutes, we will take a break for a few questions then, and then we'll get into our progress report. So we've asked both Hunt and Doug to sort of talk about their stories, what's happening in their communities, how they're utilizing multiple different approaches to exchanging health information exchange, and some of the challenges they're tackling, and how they see health information exchange evolving in the future in their communities. So, and doing all that, by the way, in 10 minutes or less. So it's going to be just a quick conversation, hopefully a quick dialogue. So Hunt, why don't you lead us off?
Sure. Thanks very much, Kate, and good afternoon, everybody. Pleasure to have the opportunity to do this. So yeah, this is the speed dating version of learning about Vermont HIE. We have a single statewide health information exchange that is operated by a nonprofit 501c3. But it is really, in many ways, an extension of the state, sort of in the electronic highway version of a bridge and tunnel authority, if you will. The governance of that organization is a small board that includes 9 to 11 members, and that includes both a representative from the administration and a representative appointed from the legislature. I serve as the administration's representative. Our funding model, which some of you may have heard about because it's quite popular and we've talked about it a lot, is an assessment of 0.2%. It's a fee that is assessed on all healthcare claims. And so that goes into what we call the HIT fund, and we utilize that for both direct grants, but really and that was established back in 2008. But of course, in 2009, after high-tech, we found ourselves in a great position because we had the match for many of the, at that time, new federal funds that were available. So we utilized the HIT fund. We've actually leveraged it quite a bit. It brings in about $3 million a year. And so we use that for both ONC match and recently through an approved state Medicaid HIT plan, IAPD, we are also utilizing that for the commercial share, if you will, for Medicaid match for HIE on an ongoing basis. So that's currently at the 90-10 rate, but it will transition to an ongoing MMIS, maintenance and operation match rate, because of one of the, used to be unique, but there are now a number of states that have moved in this direction, including Massachusetts, where the infrastructure of our state MMIS and soon to be insurance exchange and eligibility system is very tightly coupled with the health information exchange, so that although this is not the case today, by the time we complete standing up all of our shared services infrastructure, the state provider directory and state EMPI will be the masters to those on the HIE. So that provides a lot of opportunity for leveraging those federal funds. In addition, a little context about Vermont, we have all of the hospitals in the state connected to the exchange as well as their labs in Vermont. Most of our lab work is actually done in the community hospitals. Over 50% of the primary care providers and specialists are connected to the exchange, and we're actually on track to have 97% of all of our providers who are eligible for meaningful use having EHRs installed by this time next year. So our next step, and this is part of why having that HIE fund comes in handy, is to expand to mental health and substance abuse services and long-term care services. And we also have a clinical registry that supports our medical home infrastructure, and I think this is one of the most important points to make about our Vermont approach, is that we have both this federated HIE structure and a centralized, with a much smaller data set, infrastructure for a longitudinal care record that can be viewed by multiple, not just clinicians, but community health workers and other folks who participate in a patient's care team. We have recently instituted a new consent program here, a new consent policy here in Vermont, and I'm going to give an example that came up actually just last week with a couple of hospitals who were interested in understanding how to utilize the exchange, how that interacted with the clinical registry, and then we also have deployed direct, and so we're using that combination of the three approaches. So our consent model is that folks provide consent to view, and so the question that had come up was, well, if physician A is making a referral to physician B, does that physician B have to wait to get the consent from that patient when they present, or you know, how can they get that information sent? And so, of course, we're using the direct protocol, like just as, you know, folks would use a fax or a courier now. So that's a good, simple example of using direct to send information on a patient related to a referral, and then when the patient presents at the referred physician, then they can provide their consent to view so that that physician could then look at other information that would be available through the exchange. Now, that scenario, is important to note, is not yet active in Vermont. It will be shortly. We are having just gotten the consent policy in the final stages of approval. We'll then be upgrading an implementation to our HIE technology itself. We utilize Medicity. They'll be doing an upgrade, and then we will actually be doing full query exchange, which is something that we've been looking forward to doing for quite some time. And I know I'm taking up too much time, so I'll just close by saying that the other important element to this whole enterprise is that, of course, it's integral to supporting delivery system and payment reforms, and we have a very close working relationship with the folks who are developing accountable care organizations and other provider-driven models, so that we are basically a public resource that is available and can be leveraged by those organizations. And I'll stop there.
Thank you so much, Hunt. You did cover a lot really quickly, very concise. So Doug, and we have your slides, so just let us know when, as you'd like to advance them.
That's great. I appreciate the opportunity as well to share a little bit. You know, my dad had a picture on his desk a lot of years when I was younger and would visit him. Had this ship that was getting battered by waves and just in a brutal ocean, and it said, "Great captains are not made by sailing calm seas." And sometimes I look at my day and say, I wish I could just be an okay captain, because I really don't aspire to be any greater than I am. But it's the environment that we find ourselves in, and it's great fun. Quick overview of Michigan Health Connect. I put a map up here to give you a sense. The blue represent the hospitals that are participating. We have 55 of the 137 or so that are in the state participating with us right now. So from a geographic standpoint, we have pretty wide coverage and cover big territories, about 39 of them right now that are live and sending data in one form or another out in and through the exchange. Next slide. To give you an idea of what we're doing, I won't go through all these in detail, but we've got about 1,100 offices that are connected today in one way or another. All these things that are on the page are live today. There's another page that are things we're working on that are not live, but save those for another day. But we are delivering results. We have 120 interfaces, EMR interfaces live that represent about 36, last count, different EMR systems. So very active there, doing the lab orders scheduled. They're primarily radiology orders right now with request to a central scheduling group. We have a pretty broad referral network growing very rapidly and doing about 4,000 real referral care transitions a month using that platform, and as I said, that's growing very fast. We have the virtual patient record, what we call our VIPER. That is that community health record. So the things above that are really push. And similar to what Hunt said, we have both the push and the pull, and I think we're going to need both of those for the long haul, depending on the particular scenario that we need to meet. And then we are as well connected to the state immunization reportable lab registry. We have about 150 offices sending immunizations today, and we're in the process of connecting our first few hospitals to actually send the reportable labs. So those, that's kind of what we're doing today. Michigan Health Connect formed in March of 2010. Some of the work had been underway in pockets prior to that point, but that's kind of give you a history on where we are. Next slide. So with that backdrop, I thought I'd spend a little time on the daunting challenge of answering the question. So, you know, for me, where's HIE going, and is a bit in part what we're developing and how we're building Michigan Health Connect. And these are some of the stakeholder drivers that I think are going to require a form of community health information exchange in the future, and things I talked about here. So, you know, exchange outside your enterprise box is a non-negotiable business imperative. There's nobody who's an island anymore. Patients aren't so convenient as to stay within a single organization. So I think that the need to connect outside of, no matter how big your box is, how much you have within the scope of your services, there's going to be some need for enterprises to connect. The basic integration of results and orders is really not a differentiator anymore. It used to be. Now it's just something that you have to do, and you're either going to pay to maintain all those interfaces, or you can leverage that into the exchange, which is part of what we talked to them about. The evolving financial risk care models, I think, are going to demand that integration with organizations you don't own. Call them ACOs, organized systems of care, whatever it may be in your market. Nobody's going to own everything, and so there's going to be a need to tie things together in a way that, as health information exchanges, RIOs, we are building that capability And if you're at risk for patients, you're going to care even more that you know what's going on outside the confines of your box, because if you're at risk for the care or for the cost, then you're going to want to know where they're going and what's happening, which I think gives us another great reason to be talking to folks. M&A activity, as the smaller hospitals continue to get sucked up. We have multiple system platforms. How do we provide an integrated view of data? I'm kind of talking to the hospitals here about killing two birds with one stone, rather than building an internal portal that kind of sits on top and layers on top of all your diverse systems. Why not just do that within the context of the community and not only have your enterprise needs met, but also be able to get the data then from the other partners in the community. You're going to spend the dollars. You spend them internally, or you can spend them with the community and have a little bit more value there. And then ultimately, the organizations are going to want and need business out from outside their box. They want those referrals coming in if they're a larger tertiary type center. Next slide. So with those being some of the drivers, how is MHC building itself, some of our guiding principles? We don't think as an HIE we have to do it all. We don't have to solve all the world's problems. What we're trying to do is fill in the gaps, and we want to collaborate, not duplicate the existing capabilities in the market. So I believe that we need to keep providers in their native systems, if at all possible, which is going to require a deep level of integration with the EMR vendors. So strategically, for example, we've decided not to offer an EMR to the provider community, because what we hear is not we have too few choices. What we're hearing from our providers is they have too many and they're not sure what to do. So we'll direct them to the rec. We'll find other ways, or even work with the health systems who are my members who have affiliate programs. I also don't want to be in competition with them. So there are a number of things that we aren't duplicating or trying to get in front of, but again, want to fill in those gaps, solve very tangible problems, and bake the solutions into the operations and the way folks do business every day. We certainly found, to run off of the Clinton thing from a number of years ago, it's the process stupid. And if we can't figure out a way to get it baked into the way people do their work, even with something as mundane as changing faxed results to sending them to an inbox, then we're not going to get the adoption we want. And that really takes a big part of our day to make sure that we're doing that. The other key thing, I think, from a guiding principle is we're very focused on building a solid foundation in core plumbing before we worry about the Mac Daddy second floor bathroom. It seems like there's a lot in HIE where we're trying to build these very sophisticated things before we've actually got some of the core data fluid and moving and find the value proposition of those sorts of things. So we are very tactically focused. We're privately funded, sustained 100% by our members. So we aren't focused on big grant dollars or those sorts of things to sustain us, and so we have to figure out kind of the old-fashioned way, how do we build the business and go out and find customers that we can do something better, faster, cheaper than they can do on their own. And ultimately what we're trying to become is indispensable, so that we're seen as being required but invisible, so that ideally someday nobody knows we're back there, kind of like the plus, Cirrus, or NYCE symbol on the back of your bank card. You don't have to care or know anymore which machine you can walk up to. They're back there doing their thing. You can just do your banking, and it's in the background. That's what I'm trying to get MHC to be. Next slide. A couple thoughts on the future as I wrap up. Well, one, direct certainly has a place for us, and it's a key tool set that we plan to use, but it's not, in my view, and these are my views as it says on top, kind of an HIE in and of itself. It's going to support for us a great deal of how do we communicate with other exchanges, how do we interact with our snowbirds who go down to Florida or Arizona during the winter and need to move that data around. It's a great tool for that. But there are other pieces and parts that we're going to need to put around it. I believe that grants aren't always going to be there, so we do have to build the business the old-fashioned way, and that we're never more focused than when we're chasing kind of customer dollars for the long haul, rather than grant dollars to keep us going. So we're very focused on that. And then if you were to press me, and nobody did, but I think the state-supported models, similar to what we just heard, or the community-supported private models that have the community support behind them, in my brain, have the best chance at existing long haul. I think the ones And it's not that any of these three won't not be successful or will be required to be successful, but I think the state-level shared service type models are probably going to struggle a bit more. They're not funded by the state. They're going to have to turn around and ask the sub-state exchanges for the funding and where that value proposition sits. And so if you ask me kind of the future of HIE, that's for me where I think things are probably going to fall down a little bit. And then I'll end on the last slide, which is really the meaning of all of this stuff. The dude on the page is my son, Ethan. Adopted him when he was 3. 2010, he spent 5 episodes in the hospital with chronic pancreatitis and has had problems since he was an infant. And at the end of the day, what we're trying to do, and I think what HIE is trying to figure out a way to eliminate that binder. I don't really care as a parent what your box is, who's in your box, who's out of your box. All I know is I have to go from provider to provider to provider, and to the extent I have to carry the notebook around to tell everybody what's already been done or tried, that's inefficient. That's not what I want. And so I think from a HIE, from a community HIE perspective, to the extent that we can get all of the boxes working together and link that into a community record that eliminates that binder, that's ultimately what we're trying to do. And with that, I will stop.
Thank you, Doug. That was fantastic, and what a beautiful little boy you have. I want to just take a few questions at this point, and I'm going to start with one for Hunt. So Hunt, the question for you, and I think you said you were going in this direction, but so does your HIE include behavioral health information and providers at this point, or is that a future plan?
That is a future plan. What we're rolling out what we're calling a hub and spoke program for substance abuse providers to pair counselors and buprenorphine prescribers with inpatient treatment centers. And one of the things that we've found a lot of problems with is not having sufficient communication between those prescribers and the mental health counselors. So it's a hybrid approach where we're enabling the counselors to see through the community health record component of the exchange, and to be able to see into the health record and then utilize direct, again, as point-to-point communication, so that our consent structure is set up so that we believe ultimately we'll be able to also handle behavioral health and mental health through the exchange, but we're crawling before we walk.
And the next one, and I'll ask you both to comment on this. Maybe this time, Doug, you can start. But so the question, and you touched on this a little bit, but on how you're using direct, each of you in your efforts. But so can you comment on if using direct, to what extent using direct will satisfy the health information exchange requirements for meaningful use stage 2? Assuming you've already studied stage 2 since it hasn't been final for very long.
Yeah, we're all experts now, right?
Yeah.
So we are standing up our direct HISP right now. Where we intend to use it, where I see that it's going to extend what we have, is in, again, when we need to communicate outside of our exchange, whether it's another HIE or another state potentially, and or if there's providers that just want to communicate with each other more on a personal basis that doesn't specifically fall in and around a referral, that platform. For us, I think that's where it has the best opportunity. I think certainly it's going to meet some of those meaningful use requirements as it gets baked into kind of the operations and get used as a transition. And I think we'll just need to figure out individually, based on the tool sets we're using, where it adds value over and above kind of the capabilities that we might already have from our vendors.
Yeah, I think that it's an interesting question about stage. I think it probably, the intent is that direct will meet the stage 2 requirements, but I think that as we look at some of what Doug was talking about in terms of really larger value adds for information exchange and aggregating data, and doing more sophisticated kinds of push information, I think that direct is, a necessary but not sufficient tool, and I wholeheartedly agree with him that it's a tool in the toolbox, but it really is not exchange in and of itself. And I think that it's going to be an interesting question to see how ONC and CMS move forward. I know in the stage 3 conversations that are happening in the Information Exchange work group for the policy committee, that this is actually a hot and heavy question, because obviously to go to something beyond direct and begins to beg all of the questions about a more comprehensive infrastructure for privacy and consent. However, my personal opinion is that's where we've got to go, that we're not going to achieve the kinds of comprehensive data liquidity that we want if we're just having EHR to EHR communication. It needs to be a much more sophisticated network of provider nodes.
Hunt, there's one more for you. I want to try to get all the questions for you and before you need to go. So could you just repeat, could you run your sustainability model for Vermont by us again? There was a question for that.
Sure. So we have an assessment that's made to all the insurance carriers, and the way that we do that is we have a state multi-payer claims database, and so on an annual basis we get a report for the previous calendar year of the total claims paid by all of the carriers. And this actually includes not just the fully insured plans, but also self-insured employer TSA plans. And we here at the Department of Vermont Health Access send out invoices. We were doing it quarterly. We just got the legislature to agree, because the insurers were much happier from an administrative point of view to have one invoice a year. So they make that payment. It goes into a fund, which is like a sequestered fund of state government, and then we utilize that primarily to, so far, because there have been so many federal resources available for match and other sort of small grants that we give out through my office. So again, it's 0.2% on all major medical claims. So not your Aflac or Delta Dental, but all major medical policies.
This next one is for you, Doug. Can you talk us through a data flow example of lab orders, for example? So where does the order get entered? Does it go to the HIE and then out to the lab and then back to the provider? And how, what is the advantage of going through the HIE rather than directly between the lab and the practice, as an example?
Okay. The two sources that we're getting the orders from today, either directly from an EMR. In the case of an EMR, we will put the lab catalog of the labs that are working with us and help work with the vendor to embed that catalog in the EMR so that when it's ordered, that information comes out with the lab's codes on it, and then we're presenting that to them in an integrated work list within the lab. So no matter what's coming from any direction outside of their organization, it all gets put in a similar way inside the lab. So we're either collecting them from the provider EMRs if they have one, and ideally that's where we will go forever, or in the interim, we've got an ordering tool for paper-based offices or others whose EMR may not have an ordering capability, that they can use our order entry tool that will get that order into the lab. And then as the lab, they can either manually enter it, they can automatically push it into their lab and HIS systems, and then as the results come out, if it's a bidirectional interface, then we'll try and get that ordering information on the result so that it queues itself up and clears itself up in that office's EMR system.
Very good. And I'm going to do maybe one or two, and then we'll shift gears to the work group reports. Next one for Hunt again on Vermont. So can you talk a little bit about what the financial benefits that have been achieved by the Vermont Health Information Exchange so far?
So far, one of the main benefits has to do with utilizing the exchange to help populate the clinical registry that I described. So that what we've done is there are about 400 data elements that are mapped from all the EHRs, exported through a CCD, and then populate this web-based clinical registry tool, which we use for population-level reporting and doing outreach and that sort of thing. We, not the provider part of we. The state government does not use that. So that is one of the integral tools of our whole patient-centered medical home and community health team initiative. And that initiative itself has been demonstrated still in the relatively early years. It was in 3 pilot communities. Last year expanded statewide to get us up to about 50, I think it's 56% of all Vermonters are now enrolled in those medical homes. And the evidence, while still early, is that we are effectively reducing the rate of hospital admissions, admissions through ER, et cetera. And a lot of that is attributed to having a more comprehensive information picture of the individual patients and being able to do more effective patient care coordination and care management. So that's really the big upside financially.
Excellent. And then the last one, and I'd like you to both comment on this. So approximately what percent of Michigan and Vermont residents currently have comprehensive personal health records, longitudinal personal health records in your HIE? And what percent do you think you'll have in a year? And when do you think you might get to 75%? So, Doug, you want to go first on this one?
No.
It's a tough one.
Yeah. So, I mean, if I'm answering honestly now, and it depends really what comprehensive is. So we've started to populate it with right now as a fairly small subset of our hospitals. So we've got, close to 1 million patients that are in our MPI right now, and about 2 million messages a month that are being posted into, kind of the repository. And there are a number of other hospitals that are in process of punching their data in there as well. So every hospital or care provider that adds their data, it makes it more comprehensive, I guess, and I think it will continue to grow over time. So in one sense, I think the answer is none. On a comprehensive view. On another, I think that we are working our way there and have a number of hospitals that are connected and more will. And I think this will really be ultimately a lifetime pursuit for us in many ways to figure out as healthcare changes, as the needs change, as what we're capturing and need to be able to display may change a little bit as the systems change. I think we're always going to be in some mode of trying to continue to round that out. Home health and all the monitoring systems and all of that, that's going to present a whole new frontier for us at some point. So I don't expect to ever be done before I hang up my shoes someday.
And Hunt, how about you?
Well, it's unfortunately an easy answer, which is 0%. We do aspire to actually implement both the personal health portal off of the exchange and blue button capability for the registry that I've mentioned. However, because of the comprehensive integrated system with the EMPI that I mentioned before, we do not yet have a uniform identity management infrastructure in place, and so we have held off on moving forward with the PHRs because of that. However, I will say that it remains an extremely high priority for us, and I anticipate having that implemented within our current fiscal year, which would be by the end of next June, because my belief is that enabling patient access to their own data is going to be one of the most important drivers to true ubiquitous use of HIE.
Bless you. All right. So thank you so much, Hunt and Doug. That was a fantastic discussion. There are quite a few more questions, but I tried to hit the big themes. And in the interest of time, I'd like to shift gears and turn to our work group reports. But thank you so much. That was really, really helpful, and I think our participants were very interested. So we may have a few more questions for you, Doug, later, but we're going to press ahead now. So thank you both.
Thank you both, and if you want, Kate, if you want to share my email with your audience, I'd be happy to try to respond to folks through.
Thank you, Hunt, and we will follow up because there are definitely some questions we probably won't be able to get to, but we'll try. So thanks so much.
Great. Thanks very much. Bye-bye.
So now we'd like to get into the progress reports for the HIE Learning Network work groups. We do have some really outstanding, some very experienced and talented executives who have volunteered to lead each work group. So I'm going to call upon them to share the progress so far. Additionally, we have a really great group of people serving on our Leadership Council, also providing kind of oversight and direction across all the work groups. So the participants and all the chairs are listed on the coming slides, but our Leadership Council are also on our website, and I see a number of our leaders on this call as well. So each of the work groups are working toward the development of a white paper to summarize their work and recommendations, best practices, and examples of some ways that we think will help contribute to the industry knowledge base going forward. And that's going to happen roughly in the October-November timeframe, and we'll get into those details. But so first, I'd like to start with the progress report on business models for financial sustainability. And we have David Weirs on the line, who's one of the 3 chair people for this work group. So David, you want to just walk us through an update?
Yeah, very quickly, let me give an update. And first, let me acknowledge and ask my co-chairs, Jeff Rose and Michael Sims, if they're on the line, please to add any comments as I go through our update. This has very much been a group effort. It's been a group effort among the 3 co-chairs and then also among a number of individuals in the HIE community who have been very active in terms of providing comments and feedback with regard to the approach that we've taken. And very quickly, in terms of that approach, what we've looked to do first and foremost, I think, is really establish a common language and a common understanding with regard to terminology as it relates to the question of defining financial sustainability for a business model or for business models as it relates to health information exchanges. I think one of the things that we came to understand very quickly upon initiating these activities is that the definitional issues are non-trivial. Language tends to get used in a variety of ways, and really coming to understand terms and terminology and really establish a common basis of understanding in regard to both operational terms and financial terms we saw as really being a first step and a necessary element in then beginning to evolve the white paper and come to describe what we did see as viable business models going forward or viable options to create business models going forward. What that then led to, and this was very much developed in conjunction with your staff, Kate, and we really appreciate their time and efforts, was creating a survey instrument, and you do have the link to the survey instrument indicated on the slide. And that survey instrument really is something where we're looking for feedback across the HIE community and really looking to try and come to understand what actions are being taken by organizations today, what approaches are being pursued with regard to the business models, and how those actions are seen in context of the overall environment. I think that the comments both from Vermont and Michigan really build upon some of the areas that we're looking to explore, things such as what are the roles of HIEs on a cross-state basis as opposed to an intrastate basis? How do HIEs see themselves being positioned subsequent to the possible expiration of grants? What really becomes the value proposition? I think that the term value proposition is one we keep coming back to very much as well. But what does become the value proposition for HIEs as they look to move forward and as they look to become, to some degree, sustaining based upon contributions and fees and really more of a revenue model in total as opposed to something of a shared resource model which may exist today. The survey itself really looks to build upon those areas and address those questions. Our intent is being able to use results of the survey in creating a white paper, but to do so in a way that we do provide a degree of meat, if you will, or quantitative assessment, even if not in extreme detail, but certainly a level of quantitative assessment with regard to what we see in the marketplace and what that then means in terms of options for business models going forward. So that's what I had.
Excellent. Very good. Thank you so much, David. And I think Jeff or Mike, I see you're on the line. Anything to add to David's outstanding report on a very complex issue that many people are struggling with? Now, that's unusual for both of you to be quiet. Are you guys on mute by any chance? I think you got, anyway, so very good. Just wanted
Actually,
to
thanks.
Hey, Mike.
Yeah.
Yeah.
Hey, thank you. Maybe the one thing I would add is, what we want to present to people is, is to take, the information that they'll be kind enough to give to us. And, based on, if you read, all the articles that are out there today, it looks like that, few HIEs are sustainable. And what we're kind of looking for with the survey tool that David mentioned a little bit earlier is to get everyone's information, take it back, and then present it back to everyone to say, this is what we thought, would be the result, is that, you're pretty much validating what, or you're not, what the, what all the literature is saying. And then what Jeff, David, and I would like to do is to show you methods and communication tools and some benchmarks to go back to all of your stakeholders to say, this is what a sustainable HIE looks like. Here's the business rationale for getting there, and here are some of the tools that we can provide you to get there. So that's what we're hoping to provide to everybody.
Excellent. Very good. So, oh, Jeff, please go ahead.
Kate, can you?
Mm-hmm. Yes, we hear you.
I'll try to be brief for a change. First, David and Mike, thank you for your comments. I would just, really encourage everyone to participate. This is, what I call sort of a Jerry Maguire moment, where we need people, to help us help you, and that, there isn't a magic or silver bullet that if people just start selling widgets, they'll be sustainable, and that, this is the hard work of analyzing what good looks like, and so we need information to be able to analyze it and feed it back to everyone. And there may be some reluctance to want to send that information to NeHC or anyone for that matter, but we really encourage people to participate in this, because we think the benefits will be terrific when we're all done.
And just to reinforce, this is Kate again, this data gathering effort, and we do have others in some of these work groups, and this one's, I just want to emphasize that no individual organization's data is going to be shared. That's going to be held completely confidential. We just want to be able to aggregate and look at patterns and look at some composite models. So thank you so much, Jeff, Mike, David. Great work to come, and some tough work behind us as well. So next up, I would like to call on Eric Kloss to sort of lead us on an update of our work group on best practices for prioritizing and phasing the implementation of health information exchange services. And obviously this group, the work is very aligned with and really closely related to the work group on sustainability as well. So, Eric, are you ready to go?
Yes. Kate, can you hear me?
Yes, I hear you clearly.
Okay, terrific. Well, first of all, I'd like to thank Kate and Merritt. They've been helping us substantially with our surveys, as well as my co-chairs, Scott and Kim Pemble, Scott Afzal, for their help and participation. Our initial goal was to develop an inventory of HIE services, and we created some categories: HIE enabling functions, basics HIE services, advanced HIE services, and then we even have begun some process of trying to develop some phases. In the process of doing that, we decided to put a survey out similar to what the sustainability group did. Our particular survey was aimed at getting a prioritization order for HIE services. We also polled the availability of certain services in the existing HIEs. And then the third thing we did is we had a set of criteria that we wanted folks to prioritize as rank the criteria as far as importance. And quite honestly, we've gone through now 2 iterations of kind of survey development. The current survey is continuing to be pushed out to the community for their input and feedback, so we certainly encourage people to continue to respond to that survey. I think, Kate, I'm not sure when the deadline is for that, but we are still soliciting input. And then the goal based on that input is to continue to refine kind of the inventory of HIE services, how we are categorizing those services, and then continue to have a dialogue around how we prioritize those services in the context of ancillary issues related to sustainability or new models of care that are emerging. You know, what we're finding is that obviously we are responsible for developing our own work paper based on our work groups efforts, but at the same time we certainly want to incorporate the activity and some of the findings, let's say, of the other groups, because they have certain bearings on how we are going to recommend the prioritization and phasing of HIE services. So that's kind of a brief summary. If Scott or Kim want to add to that, that's kind of where we are right now.
I think that you're our only chair for this work group with us today. I think so your report will go unedited. Good job, Eric. And just to make to answer the question, so the deadline for the surveys is September 19th in order to give us some time to do the analysis and incorporate the conclusions into the paper development and recommendation. So the 19th is the deadline, and I'd just like to take this chance to encourage everyone on the line, and we've got great participation. For those of you that haven't completed these surveys yet, we'd really appreciate you just taking some time and completing these surveys. So, and we'll have a slide at the end. We actually have the survey, links to the survey are on our website, and we'll show you exactly where the links are on each of these, but we'll describe that too. So thanks so much, Eric. And
you're welcome.
Lots of great work, and this the work of this group on the HIE services also ties in pretty closely with our next work group. So next up, we'd like to talk about the work group on HIE functions to support new payment and delivery models. So within that broad list of HIE functions, we're really trying to think through with this group which of those services do we need for the new payment models, the new delivery models, et cetera. So Laura Kolkman is with us, and she's one of the 3 chairs for this work group. So Laura?
Okay. Thanks, Kate. Can you hear me okay?
Yep, you sound good.
Okay, excellent. So I too would like to offer my thanks to Kate and Merritt and others that are supporting this at NeHC, as well as to my co-chairs and everyone that's participating in the group. We've got a pretty good-sized group. As Kate mentioned, our job is really to understand the key functions or capabilities that an HIE needs to bring to the table in support of the new payment and delivery models. So after some discussion, we decided to separate out delivery from payment models. And as you can see, we too are part of the survey group. And what we did was we categorized the services, the capabilities, into 3 major areas, and we called them advanced HIE services, patient-focused HIE services, and value-added services, and then put a list under each of those. And the survey is going out to understand perspectives both from the delivery models and the payment models, realizing that those may be separate services. And then also asking questions about payment analytics and so on. And I believe, as Kate said, our survey also is open until September 19. We have some preliminary results back, which, since the survey is still open, Kate, if you don't mind, I'm not going to share because I don't want to skew the survey. But we also did, in our last work group, just a bit of a real-time polling amongst our members, just to help us inform the white paper as we move forward with that. And we just asked, kind of in 5 years, what % of the market, including public and private payers, did our work group think would be in shared risk arrangements? And by a long shot, well, 38% of us said between 50 and 60% would be in this type of market. And another question we asked was, what do we think the implications of the shared risk arrangements will be on Health Information Exchange? And by a large margin, 88% said it would dramatically increase the need for HIE. And then 2 more questions. What are the most important engagement tools? And 44% of us on the call said chronic care management, 39% said patient-provider communication. And then last but not least, how is your organization positioning for success? And it was really a tie. 38% said they were developing intelligent business intelligence capabilities, and 30% also said that they were serving as HIE infrastructure to an ACO. So I think we've got some pretty good basis to move forward on. We too crave your input on our survey. We also will be looking at case studies to help us better understand how HIE might be used to support these new delivery models and care models. And then next steps, obviously, to review the results of the survey, to reach some consensus on the issues and how to address those, and then write up the paper. And I think that's it. Kate?
Perfect. Thank you, Laura. And this work group, I think, I think it's clear folks realize that the economic pressures are driving this transformation. It may not really be about healthcare reform officially, but I think the pressures are driving it, the payers are driving it, and so there is a need for this HIE function to support these new models. So I think the outcome will be interesting to all, and I also think we'll have a next phase likely of this work once we get past our initial work. So thanks, Laura, and I am going to report on our final work group since our chairs for this one were not able to join us, and I'm ill-equipped to do this since addressing variations in implementation of interoperability standards is not my area of expertise. Those of you who know me know this well. But I think that with this group has been doing some very good work as well. And I will start by saying that the work is not about developing standards. I want to emphasize that. This work group is really focusing on sort of understanding. So we've developed and iterated and refined what we're calling the elements of advancing interoperability. So it's sort of focused on some threads of process around standards and certification and other major functions. We've also come up with and vetted among the work group sort of a list of measures of success for interoperability to sort of lead to the definition of an ideal end state against which we can measure progress. And the work group has also developed a list of coalitions that are out there and initiatives that are out there that are working on interoperability-related issues. And we've done this in order to make sure that we are building on the existing work out there, because there is a lot of existing work out there in lots of different forums, and to make sure that we're building on that and we're not duplicating. So we're in the process right now of sort of validating with these other groups that we indeed understand what they're doing and bringing them in to advise as needed and appropriate to this effort. And then finally, the focus of the white paper that we're working toward is to really expand the general understanding of the barriers or gaps in the interoperability development process by examining each of these elements more deeply, trying to prioritize the parts of the process that may lead to breakdowns or further gaps, and then provide thoughts and recommendations on how to address those potential process breakdowns or gaps. So that's sort of the focus and the scope of this work group. So that sort of concludes our progress reports on these. And I'm just going to quickly scan the questions. We're pretty tight on time. Oh, thank you. So we have on the screen here, I do want to really encourage everyone who hasn't already completed these surveys to come to our website, to go to the links, and to complete these surveys. So really all you need to do is go to our website and click on the Learning Network link, and then go into each of the workgroup pages, and you'll find the links to these surveys. So I would really encourage you to do this. Again, we have about a little bit more than a week, or I guess exactly a week from today. We've got the deadline of September 19th for this. So please do complete these surveys. And then finally, I would also like to make sure everyone is aware that the initial results of these work groups, the white papers, the recommendations, etc., is going to be presented and discussed at a conference here in DC at the end of November. In fact, the special track on Health Information Exchange is going to be on the afternoon of November 28th. But this is a special track in a broader conference, the Technology Crossroads Conference, that is exploring the intersection, if you will, between the use of audiovisual technology and health information technology. So again, the details are on our website, but this is going to be the forum for discussion of these workgroup results and the next phase of the work for the Health Information Exchange Learning Network. So with that, I think I'm just going to take a quick peek at the questions here. Oh, the question here, again, there was one again. So where do we go to participate in the data gathering efforts? And that is, if you want to go back to the links, it's on the website, in the HIE Learning Network, on each of the pages for the work groups. And there's actually three of them. And then we do have a request for Doug's email. So Doug, I think you're still on the line, and if you're okay with it, we can share your email with the person who is requesting that. That's okay. And I don't see any other questions or comments specifically on the workgroup reports. But for those of you who had questions for Doug or for Hunt that we didn't get to, we will try to follow up and get the rest of those questions answered and posted and sent back out to you. So with that, I would just like to thank everyone for joining us, and in particular Hunt and Doug for setting the stage up front, and for the workgroup chairs for all of their hard work and all of their leadership on these tough issues. And thanks everyone for joining us, and we hope to speak with you soon. Goodbye.
Thanks, Kate.
Bye-bye.